Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. No, you're not hallucinating. At least I don't think so. And yes, these glasses are awesome. But no, I can't see through people's clothes with these. Or can I? Oh well. Today's lecture is on neuroleptic drugs, also known as antipsychotics. First, I want to do a quick overview of schizophrenia and psychosis. So, for schizophrenia, it's a severe mental illness in which the patient loses contact with reality. Now, it has increasingly been recognized that this can be a collection of neurodevelopmental disorders, and it can involve alterations in brain circuits. So this implies that structural and functional changes in the brain are present even in utero. And in some patients, they can develop during childhood and they can develop during adolescence, and there's even repercussions of this into adulthood, obviously. Now, this occurs in the population somewhere between 0.2 and about 1% of the population. It's more common in men. There's a ratio of about 1.4 to 1, with the men being predominant. Now, the etiology is confusing. Now, there's a very strong genetic predisposition. 50% concordance is found in monozygotic twins. But sometimes we see this more often in certain neurological disorders. There's even been a hypothesis that say possible viral infections might be a triggering mechanism for schizophrenia. There's also psychosocial factors. It's very interesting that there's a higher prevalence in urban areas. So cities over 1 million people tend to have higher prevalences of schizophrenia than in smaller places. In fact, it's nearly absent in cities where there are fewer than 10,000 people. And it's also very, very high in our homeless populations. There's been some studies that have quoted numbers like 33 to 67% of our homeless population is somehow affected with schizophrenia or schizoaffective disorder. Now, the peak onset of schizophrenia is usually in the early 20s. Sometimes it's a little bit later in females, but most of the time in males you see it in your early 30s, but you can still see it even earlier than that in your teens and even later into your 30s. And this is also very interesting because this is also about when young adults are moving away from home. So men and women are moving off to college or going into the military, and there's a interesting phenomena where onset of paranoia happens and then they have to return home, and there's some confusion on, well, maybe this is adjustment disorder, are they not doing well in a new environment, or is this something much worse like schizophrenia? The lifetime suicide risk is about 5 to 10%. And you'll see a lot of varying numbers regarding how often people with schizophrenia attempt suicide and are unsuccessful, and those that are successful with their attempts. So symptoms. So the symptoms of schizophrenia are wide-ranging. Usually we categorize these as either negative or positive symptoms, and this can be a little misleading. Negative doesn't necessarily mean a bad effect, and positive means a good effect. Negative indicates that it's a phenomena where you're losing a normal part of your personality or normal part of your physiology. So the negative effects include flattening or blunting of the affect. You can get a poverty of speech. Blocking. Blocking is a sudden halt in the train of thought. Lack of motivation. Anhedonia. Social withdrawal. Cognitive disturbances. Poor grooming is another one. And then we have our positive effects. And positive doesn't mean good. Positive means these are things added to the personality or added to the mental status that shouldn't be there. So these include hallucinations. And what's the most common form of hallucinations? Well, those are the auditory hallucinations. So remember that for testing. Delusions. Loose associations, so you can have a sudden shift in subject. Patients will be talking about one thing and just without a beat switch to a different subject very quickly. And then talkativeness or strange behavior. Now, some of your most interesting experiences in med school or in other training programs will be in your inpatient psych wards. The conversations you'll have with a person who is severely psychotic will leave an impression on you that'll stay with you for a long time. And what's even more amazing, this is probably why it will really stick with you, is that you'll come back the next day after interviewing a patient with severe schizophrenia or some form of psychosis, and they'll be acting completely normal. And the reason why they're back to normal is that they're on their medication. So it can be a very interesting and rewarding experience to start with a patient with a major psychotic break and to see them improve relatively rapidly. So we couldn't talk about a psychiatric subject without talking about DSM-4. So let's talk about the diagnostic criteria for schizophrenia. So there's usually 3 things that you have to get. First, you have to have at least 2 of the following things that we're going to talk about here, and it has to occur during a 1-month period. So you have to have delusions, so that can be irrational belief that cannot be changed by rational argument. Hallucinations, and again, we said earlier, the most common is auditory. Disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. So like we said before, anhedonia, apathy, all those type of things. So you have to have 2 of those within a span of a month. Now, in addition to those things, you have to have 2 other criteria, and that it has to have some sort of social or occupational dysfunction associated with it. And then the other one is a duration of 6 months. So somewhere mixed in here, you have to have these symptoms, at least 2 of them within a month, but then the overarching symptoms of these things have to last for at least 6 months. All right, next we're going to talk about some biochemistry. I know sometimes we don't like to do this, but it's important. We want to know why people have schizophrenia, why they have hallucinations and psychotic breaks. So we have a few hypotheses here for what's causing these things. And the first one is the dopamine hypothesis. Now the basic tenet of this hypothesis is that there's an increased amount of dopamine in the mesolimbic area of the brain. Now this tends to be responsible for a lot of the symptoms of psychosis, especially the positive symptoms. Now this first concept to be developed was important, but it doesn't seem to be the full story. There's further research that might cast doubt that this is the only neurotransmitter that's causing hallucinations and therefore schizophrenia. Now, let's talk about some of the reasons why we think dopamine is still a primary actor in schizophrenia. Well, first, a lot of the medications are dopamine blockers, and they tend to improve the symptoms of schizophrenia. So many of the antipsychotic drugs strongly block dopamine receptors, the D2 receptors. Remember that D2, that's very specific for the problems we're talking about today. And it's blocking these specifically in the mesolimbic and the striatal frontal system. Now conversely, drugs that increase dopaminergic activity, like levodopa that we use in Parkinson's disease, amphetamines that people use recreationally. Also, there are some clinical uses for them as well. And then bromocriptine. And bromocriptine actually increases dopamine to help treat hyperprolactinemic states. So all of these things will worsen schizophrenia, and they'll worsen psychosis. Or they'll actually produce psychosis in patients without a history of mental illness. And then finally, dopamine receptor density has been found post-mortem to be increased in the brains of schizophrenics who have not been treated with antipsychotic drugs. So people who had schizophrenia, never on medications, they're still seeing an increased receptor density. Now our next hypothesis is the serotonin hypothesis. So while researchers were studying the effects of LSD, the hallucinogen, they were looking at what type of receptors were responsible for the hallucinatory effect. So they were looking at serotonin receptors, and more specifically, they were looking at the 5-HT2A receptor, and they found that that seems to be the receptor that causes most of the hallucinations associated with LSD. Now, one of the mechanisms of action of the atypical antipsychotics that we'll talk about later, again, the 5-HT2A receptor, is that they block those receptors, and that tends to help the symptoms of schizophrenia as well. So that's more evidence towards serotonin is at least playing some role in the production of hallucinations and psychosis. Now our final hypothesis is the glutamate hypothesis. Now glutamate is a major excitatory neurotransmitter in the brain. Now PCP, or phencyclidine, also a known hallucinogen, and ketamine, which we've used for anesthesia for a long time, they both inhibit NMDA receptors. Now these ultimately will lead to disinhibition of glutamate and a hyperstimulation of the cortical neurons. So both of these agents, the PCP and the ketamine, worsen both cognitive impairment and psychosis. And this is even more pronounced in patients with schizophrenia. So we're looking more into research to help affect this pathway. But increasing this glutamate activity tends to have some form of effect on schizophrenia and psychosis in general. So now let's talk about the things we're here today for, neuroleptic drugs or antipsychotics. So the first section of the lecture here is going to be about the actions and the adverse effects of the antipsychotics. Now sometimes I'll divide these sections out where we have, well, this is what the drug does, and later on we'll talk about why we don't want to use these drugs because there's adverse effects. But you'll find out that a lot of the actions and the adverse effects are really intermixed. Some things that are very positive are also very negative to the body. So these are difficult medications to tolerate. So that's why we're sort of mixing in both the actions and the adverse effects. So first, there's an indication for the neuroleptic drugs in general for schizophrenia, bipolar disorder, delirium, mania, agitation, mood disorders, and they can also be used as antiemetics on occasion. Now the primary action of the neuroleptics are again on the dopamine and the serotonin receptors. So we talked about those hypotheses just a second ago, and now we're finding out why these drugs work, because they're working on the very receptors that tend to be causing our problems. So they have varying degrees of blockade on other receptors as well. So this includes cholinergic, adrenergic, and histaminergic. Now we're unsure how much this affects the actual mental status of our patients. So whether or not this is contributing to the schizophrenia or if it's contributing to the overall treatment, we're not sure. But we are sure that a lot of these receptors will affect the side effects. And we'll talk about those individually as well. So the positive effects, remember we talked about that earlier, the positive effects, things that you're not supposed to have like hallucinations and delusions and talkativeness and all that type of stuff. So the positive effects of schizophrenia are treated well by the dopamine receptor blockade. So you're blocking the dopamine, you tend to get rid of your hallucinations. But the negative symptoms like anhedonia, apathy, cognitive impairment are not very well treated by that blockade of dopamine. Now the negative effects are better treated by the atypical antipsychotics, and they tend to have more serotonin blockade. So it's not clear-cut that serotonin works only on negative and dopamine only works on positive, but there does seem to be some correlation between the atypical antipsychotics, serotonin, and negative effects. Now, all the neuroleptics have a profound calming effect, and they can decrease agitation. And as we talk about more specific medications, we'll talk about where we use these medications. But a lot of times, for acute agitation, we like many of these medicines. Now, histamine, H1 receptors, can also be blocked with a lot of these medications, and it can cause some significant sedation. So you'll find with a lot of these medications, they make people sleepy. Now, it isn't just the histamine that's causing this, but it's still a large part of it. Another big effect is anticholinergic. So this also varies from drug to drug. And what do you get with anticholinergic effects? So you'll get blurred vision, dried mouth, confusion, urinary retention, constipation. And the anticholinergic activity is very interesting in these medications because it seems to help decrease extrapyramidal side effects. And we'll talk about extrapyramidal side effects here in a little bit. But it seems that the medications with the highest anticholinergic effects tend to have the lowest incidence of extrapyramidal side effects. Next, there's alpha adrenergic blockade. So what do your alpha adrenergic receptors do? Well, they're in charge of your peripheral vasoconstriction. So by blocking these, you tend to get a decrease of vasoconstriction, and you can end up with hypotension or orthostatic hypotension. So that's an important thing as well. Something that's interesting, you get poikilothermia. So your body temperature will vary with the environment. You're not able to maintain a real constant temperature. You're at the mercy of your environment. You can get increased prolactin levels. So this makes sense. So dopamine inhibits prolactin release. So what happens when you get rid of all your dopamine? Well, obviously you're going to get increased prolactin, and this can lead to galactorrhea. This can lead to amenorrhea. So it's very, very important. Antiemetic effect. So due to the D2, remember we talked about how these drugs work on D2 dopamine receptors. Because of that blockade in the chemoreceptor trigger zone in the medulla, you'll get a great antiemetic effect. Now, sometimes we don't use these medications very often just for anti-emesis because there's lots of side effects that come along with it. But with some of our chemotherapy patients, especially if they're resistant or unable to take some of our other antiemetics, we'll use things like haloperidol or some of the other ones to help with nausea and vomiting. Now, patients with schizophrenia have a higher risk of diabetes mellitus in general. So even without medication, there's a higher incidence of diabetes in schizophrenics. However, the antipsychotics, especially some of the atypicals, you'll see an even greater increase in risk in diabetes mellitus. And this might be due just to the weight gain that tends to happen with a lot of these medications, but there seems to be some sort of increased risk in and of itself with taking these medications. So oftentimes you'll want to check a fasting blood glucose before and after starting these medications. Also importantly, increased lipid levels. So again, maybe this is due to weight gain, but you need to be checking fasting lipid panels and then monitoring lipid panels after starting these medications. Now, all of the antipsychotics may lower the seizure threshold, and you have to use a lot of caution if you're going to start these medications on patients with epilepsy. All of the antipsychotics have a warning, and this is a big black box warning that you'll see on websites and all sorts of things that you look up drugs in. So there's an increased risk for mortality when using antipsychotics in the elderly, especially the elderly with dementia-related behavior. And so it can be very difficult with our elderly patients. How much of their behavior disturbances are a result of aging dementia, Alzheimer's disease, schizophrenia, or other types of psychosis. But there's an increased mortality, and it's not entirely clear why we see that and whether or not it's specifically to these medications, but the statistics do say that there's an increased risk. Very important, neuroleptic malignant syndrome, potentially fatal. So remember this one. So it's a reaction to the neuroleptic drugs, and it consists of muscle rigidity, fever, altered mental status, stupor, unstable blood pressure, and myoglobinemia. There's a 20% mortality rate. 20%. 1 in 5 people are going to die if they get this. So you have to be very, very careful. So what do? Well, you need to stop your antipsychotic, obviously. Now, you can use things like bromocriptine, which will increase dopamine. You can use things like benzodiazepines and dantrolene, and these will decrease muscle rigidity, because the muscle rigidity can be dramatic to where they can't walk, they can't move, and that can be the reason behind their myoglobinemia and subsequent death. This is very, very tricky. I can recall a colleague of mine from residency who was out in a little bitty town working in an emergency room. And he had a patient come in sort of semi-altered and was told by one of the nurses who works there regularly that he was a frequent flyer, schizophrenic patient. And he would very commonly get off of his medications, and then he would have a psychotic break, and then he would come into the emergency room and he would have to get back on his meds, and he generally did okay. So he seemed a little stiff, but as we'll talk about here in a little bit, one of the side effects of medications can be stiffness. And he didn't have a fever yet. So my friend gave him an IM dose of haloperidol, and within minutes he started having 104 fever. He got more muscle rigidity and started dying. So it can be a really tricky thing when someone comes in slightly altered and they have a known psychiatric illness. You know, you don't want to just immediately grab for antipsychotics. Now, you can't check everyone for myoglobinemia who come into the ER, but still, you always want to keep in mind, if anyone has any fever or looking a little off, you want to make sure you're not making your neuroleptic malignant syndrome worse by adding an antipsychotic. Next, we're going to talk about the extrapyramidal side effects. Now, this is an important topic, and you're bound to have some test questions about this. So let's talk about the biochemistry of this first. So normally there's a balance in the striatum of the brain between dopaminergic and cholinergic neurons. Now, dopamine will inhibit the excitatory actions of the cholinergic neurons. So when we're giving our antipsychotics, we're blocking the dopamine in this area. So this will result in an excess of cholinergic activity. And this is what we think results in the extrapyramidal motor effects. Now, these effects are time and dose related. So the higher the dose and the longer you're on these medications, the more likely you are to get the extrapyramidal side effects, or EPS effects. So let's talk about what happens when you get EPS. So akathisia. So this is a restlessness. Sometimes it's described as an anxious feeling. So you can't stop moving. You feel like you just got to move. So it's often accompanied by this voluntary movement. So it's not like a tic where you're moving off involuntarily. You're just feeling like you got to keep going. So this can happen in the limbs. It can happen in the trunk. And it can start even as early as 2 weeks into treatment with the antipsychotics. Now, patients will complain of discomfort in the knees. This is a common complaint. And they'll pace around for hours because the pressure of walking will feel good on their knees, and it'll decrease their discomfort slightly. Now, you can also get Parkinson's syndrome. So you'll get rigidity. You can get a tremor. You can get bradykinesia. So this is a difficulty initiating movements. You can also get acute dystonic reactions like torticollis. So you'll have people with their neck all in a twist and get very, very stiff. Now, the big one, and you're bound to get a lot of test questions on this, is tardive dyskinesia. So this appears after prolonged use of the antipsychotics. Usually months to years have to go by before this problem occurs. And it can be permanent, and that's the big part about this, is that even after you stop some of these medications, tardive dyskinesia will persist. So what does it consist of? Well, you get oral, facial, and lingual dyskinesia. So you'll get protruding tongue, you'll get puckering, you'll get smacking, you'll get this chewing movement. So you'll see people kind of doing that all the time, and it looks really, really bizarre, like they're just sitting there chewing on a piece of gum, but it's really pronounced and obnoxious, and it's really troubling for patients who have this. Now, you can also get dyskinesia of the limbs, so you'll get sort of a difficulty moving your fingers. You'll kind of do this sort of thing, or you'll have them on your lap and you'll be doing this. Dyskinesia of the neck and the trunk. So again, like the acute dystonic problem, you can get a chronic problem where you're having torticollis, or you'll get shoulder shrugging. So people will be doing this or kind of have this hunched shoulder look because they can't relax their shoulders. So what do we do to help to counteract the extrapyramidal side effects? So since we just described that it's this increased cholinergic activity, well, why don't we use an anticholinergic drug? Well, that's exactly what we do. The most commonly used drugs are benztropine and diphenhydramine, which is just regular old Benadryl. So sometimes it can be used on a regular basis, but it can also be PRN. So patients will have this, and if they're starting to feel maybe a little stiff or they feel a little antsy, they'll take their medication, and it tends to help.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
What do we call the unwanted movement symptoms associated with chronic use of typical antipsychotics like haloperidol and chlorpromazine? I'm waiting. We call these extrapyramidal effects. Now, name some specific extrapyramidal side effects. Stop stalling. Either you know it or you don't. And you don't, do you? The extrapyramidal effects include dystonias, tardive dyskinesia, akathisia, and Parkinson-like symptoms such as rigidity and bradykinesia. And what is the mechanism that causes these effects? Blockage of dopamine receptors, especially in the nigrostriatal pathways of the brain. Why are you wasting everyone's time? Why are you shaking? Do you have extrapyramidal effects? Stand still.
Okay, so let's go through quick review number 1 in your study guide. The first question, what are the 2 major receptors that antipsychotic drugs affect in order to improve the symptoms of schizophrenia? Well, the receptors are the D2 dopamine receptors and the serotonin receptors 5-HT2A. 5-HT is the chemical abbreviation for serotonin. So these are the serotonin 2A receptors. Remember that drugs that act on dopamine receptors tend to treat the positive symptoms of schizophrenia, and drugs that act on serotonin receptors tend to treat the negative symptoms. Next question. Antipsychotic medications that have a lower incidence of extrapyramidal side effects generally cause an increase in what neuronal activity? Well, this is anticholinergic activity. Remember that the more anticholinergic activity a neuroleptic drug has, the less likely it is to cause the extrapyramidal side effects or extrapyramidal symptoms. Next question, which patients have an increase in mortality when taking antipsychotic medications? Well, this is important. Elderly patients with dementia-related psychosis have an increase in mortality when taking neuroleptics. Next question, a patient who is currently being treated for schizophrenia is having problems with galactorrhea. Explain the probable mechanism of this symptom. Well, remember that dopamine inhibits the production of prolactin, and antipsychotic medications decrease the amount of dopamine in the brain, so you get more prolactin, and excess prolactin can lead to galactorrhea. Next question, what is the treatment of neuroleptic malignant syndrome? Now, neuroleptic malignant syndrome is relatively rare, but it's potentially life-threatening and very dangerous, so it's really important that you know how to recognize this and know how to treat it. The treatment for neuroleptic malignant syndrome is to, first of all, stop the antipsychotic. That's the most important thing you can do, is stop the drug so you're not putting more drug into the system. The second point is supportive care. This can take a lot of different forms depending on how the patient's presenting. You need to give IV fluids and make sure they don't get volume depleted. You may need cooling blankets in order to keep the fever down and reduce the temperature. If the patient's having ventilatory problems, you may need to intubate them and put them on mechanical ventilation. You need to monitor for arrhythmia and treat for arrhythmia if present. And you need to control the blood pressure because these patients can have hypertension. You can also treat with bromocriptine to restore dopamine activity. Remember, bromocriptine is a dopamine agonist, and usually want to continue this for about 10 days after you've got the neuroleptic malignant syndrome under control. Continue bromocriptine for 10 days and then slowly taper them off bromocriptine. You don't want to just abruptly stop bromocriptine because that'll throw them back into neuroleptic malignant syndrome. And then finally, you can use dantrolene or benzodiazepines if you have a lot of muscle rigidity to help relax the muscles and prevent that problem. Next question. According to the DSM-IV, for how long must a patient have symptoms in order to be diagnosed with schizophrenia? Well, remember the criteria for schizophrenia include symptoms for at least 6 months. And this is a pretty common test question. You'll see a patient with acute psychosis or persistent psychosis for 3 or 4 months, and the test writer is trying to bait you into diagnosing schizophrenia. But to make the formal diagnosis of schizophrenia, according to DSM-IV criteria, you have to have symptoms for 6 months. So you really need to know that. Next question. A patient who was started on an antipsychotic 1 month ago is having difficulty sitting still and feels very restless. What side effect is this patient experiencing? Well, this is a classic description of akathisia. Akathisia is voluntary movements triggered by this feeling of a compulsion to move. You get this restless, uncomfortable feeling you just got to move around. And you'll see patients kind of, they look like they're dancing. They're just kind of, they've got to keep moving all the time. Or they'll have these repetitive movements with their hand. And it's not that they're tremor. It's not that they're having uncontrollable movements. These are voluntary movements because they feel better. They get this urge to move. And this can start relatively quickly. It can start within a couple of weeks after starting treatment with a neuroleptic. So you need to be aware of that and be able to recognize it. And then the next question, a patient who's been on long-term treatment for schizophrenia presents with strange smacking movements of the lips. So you look at the patient in there. They've constantly got their lips and jaws moving like they're chewing gum. What is this side effect? Well, this is tardive dyskinesia. It looks bizarre. It can be very pronounced. It makes you kind of think, why is this patient doing this? This person's so weird. Why are they doing this? They're telling strange stories because they're psychotic and they've got their lips going. It makes you kind of wonder, is this a weird presentation, a weird manifestation of the psychosis, or is this tardive dyskinesia? Remember, tardive dyskinesia occurs more with long-term use of neuroleptics, and it may be permanent, even if you stop the drug. I remember a patient in medical school who had very pronounced tardive dyskinesia, and that's why it's burned in my brain. And this patient was on a drug that shouldn't cause tardive dyskinesia, but the truth is she had been on an older neuroleptic years before and had developed tardive dyskinesia, and it was permanent. We couldn't make it go away. So that's it for quick review number 1. Let's go back to Dr. Lewis.
So next, let's move into more specific classifications of the antipsychotics, and we'll start with the typical antipsychotics. They're also known as conventional or first generation. Now, the antipsychotic medications in this category have been used for over 50 years. It's been something we've studied for a long time. Now, they were originally developed to treat schizophrenia and psychosis, but they're also used today for bipolar disorder, acute agitation, delirium, impulse control, and even depression, though not so much with the typical, more with the atypical. And we'll talk about clozapine in a minute, but except for clozapine, all of the antipsychotics, the typical, the atypical included, they all have very, very similar efficacy. So you can almost just pick one out of the bag and they're all going to work about as well. Now, most notably, the typical antipsychotics are known for greater risks of EPS or extrapyramidal side effects. So they have between a 5 and a 7% per year cumulative risk of late onset tardive dyskinesia. So if you're going to use the typical antipsychotics, you have to be aware of this ongoing risk of causing tardive dyskinesia, a potentially permanent problem. So it's also associated with increased prolactin. So as we mentioned before, because of the dopamine activity in these drugs, you can get increased prolactin, and this will cause galactorrhea and amenorrhea. You can also get prolonged QT interval, and this is possible with generally all the antipsychotics, but it's even more common in the IV preparation of haloperidol. Now, there's two classifications within the typical antipsychotics. There's the high potency, which are probably used a little bit more often, and they include things like haloperidol and fluphenazine is another one. And they are more likely to produce the extrapyramidal side effects. The low potency typical antipsychotics, like thioridazine or chlorpromazine, also known as thorazine, they have less extrapyramidal side effects, but they have more sedation and more weight gain. Now, haloperidol is probably the most commonly used typical antipsychotic now, and it's still used as an oral medication, but it's probably maybe a little bit more often used as an IM or intramuscular injection to treat acute agitation. So if you're in the ER and you have a patient come in, though we just talked about neuroleptic malignant syndrome, patient coming in with acute agitation, oftentimes we'll grab for haloperidol. But now even that's being replaced a lot by the more current atypical antipsychotics. Haloperidol and fluphenazine are available in a depot IM injection, so it can be a slow release. And you can give this about every 2 to 4 weeks. It can vary depending on symptom control and side effect profile. Now, as I said before, most of these medications have been replaced by the atypical antipsychotics, but they're super cheap. So in other countries and also in places that maybe are having to use cheaper medications for various reasons, you'll still see things like haloperidol used. So here comes a big part of our lecture, the atypical antipsychotics. So these are second generation, unconventional or non-conventional antipsychotics. And this is what you're going to run into more often than anything else in the antipsychotic classification. So, but we need to mention again, they're no more efficacious than typical antipsychotics, other than clozapine. And we'll talk about that here in a little bit. So the risk of EPS or extrapyramidal side effects and tardive dyskinesia is lower in the atypical antipsychotics. Very important to remember that. So their incidence is between 0.5 and 1% per year cumulative occurrence. So how high was it for the typical antipsychotics? Well, remember it was between 5 and 7%. Well, now we've dropped this all the way down to 0.5 and 1%. So you're not going to get the permanent tardive dyskinesia problem near as often in the atypical antipsychotics. So they have a similar blocking mechanism of the D2 receptors in the brain, but many of them also partially block serotonin receptors. And this is, as we talked about in the hypothesis before for what causes schizophrenia and psychosis, they're blocking the 5-HT2A and they're blocking the 5-HT1A. And this, again, might be responsible for some of the improvement in the negative symptoms of schizophrenia. So remember, both these medications work great for positive symptoms. They're great at getting rid of hallucinations and things that are bizarre. But the anhedonia, the apathy, the just not wanting to do anything symptoms, and depression tend to get a little bit better when you're starting to block these serotonin receptors. So now we're going to talk about specific medications that you're going to need to know by name, know what makes them unique, because we all know that they're blocking dopamine. To some extent, they're blocking some serotonin, but now each one of these has a little bit of a unique flavor to them, and you need to know more about them. So risperidone, or also called Risperdal, is the brand name. This is the most widely prescribed antipsychotic in the United States right now. And why? Well, because it works well. It's an atypical antipsychotic, and most importantly, it's cheap. It's a generic now, so it's being prescribed much more often than some of the other ones that are more expensive. So it'll treat schizophrenia. It'll treat acute mania. It can be a maintenance therapy for bipolar disorder. It can be used for acute agitation. Now, there is a somewhat higher risk of EPS, extrapyramidal side effects, especially akathisia with Risperdal. And this is thought because there's almost no activity of muscarinic receptor activation. There's no anticholinergic effects with risperidone. Remember how we talked about the mechanism of the extrapyramidal side effects. That increased cholinergic tone tends to be stimulating the extrapyramidal side effects. So Risperdal is not blocking any of that cholinergic effect, so you're going to get a little bit more EPS. Now, when we compare this to the typical antipsychotic, it's still a lot less. So it's not like you're just going right back to typical antipsychotic levels of EPS risk. It's still quite a bit less, but when you compare it to some of the other atypical, then you're going to see slightly more EPS in the Risperdal patients. There's an oral form. There's also a rapid disintegrating tablet, and that's really good to use in the emergency room when maybe you're not going to get a cooperative patient. It's also good to use in patients who have questionable compliance. Some people will cheek their pills and spit them out later, but when they have the dissolving pill, you can't do that because it's just going to be gone in a few seconds. There's also a depot preparation, and you can give this IM every 2 weeks. And again, that's mostly for your questionable compliant patient. Now, you're still going to get a lot of weight gain with Risperdal, so that's a major side effect that patients don't like. And you're also going to have elevated levels of prolactin, and that can be, again, a cause of galactorrhea and amenorrhea. Our next medication is olanzapine. The brand name is Zyprexa. So again, it's used for similar things. Schizophrenia, bipolar disorder maintenance, acute agitation. It's used a little bit more often in Tourette syndrome and some of the OCD syndromes. It's available in an oral form that also has a rapid disintegrating tab and an IM version. Generally, it's well tolerated, but you can get a little bit more sedation. You can get some constipation and dry mouth. And what do you think that's probably from? Well, it's probably from anticholinergic effect. Now, you do tend to get more weight gain and more incidences of diabetes with Zyprexa or olanzapine than maybe some of the other atypicals. So that's one thing you need to remember with olanzapine. Quetiapine is also known as Seroquel, and it has very similar indications as well with schizophrenia and bipolar and agitation and so forth. It's also used off-label for insomnia. So I'd have patients who had failed a lot of the other insomnia medications but had done very, very well on low doses of Seroquel. Also, and you'll maybe even see commercials of this now because there's a big push for this right now, is that lower doses of Seroquel are now being used as add-on therapy for depression. So people who have refractory depression, maybe they're already taking SSRIs or SNRIs, and they're just not getting better. Well, now we're starting to add on low doses of antipsychotic, atypical antipsychotics more specifically, and Seroquel tends to do pretty well. Now it has strong histaminic, cholinergic, and alpha-1 adrenergic binding. So this leads to our anticholinergic effects: sedation, constipation, dry mouth. And you can also get some orthostatic hypotension, because remember, when you're blocking alpha-1, which is in charge of your peripheral vasoconstriction, then you can lose some of your blood pressure. One of the other unique features of quetiapine is that it has a low incidence of extrapyramidal side effects, even at high doses. And again, this is probably because it has a strong anticholinergic effect. Our next medication is ziprasidone, and this is also known as Geodon. Again, it has very similar indications as our other antipsychotics. Some distinguishing factors of ziprasidone: it has mild QT prolongation, so you need to be careful in cardiac patients. One of the advantages of ziprasidone is that it has a low risk of weight gain and diabetes. So people like Geodon because it doesn't make them gain as much weight. Next, we're going to talk about aripiprazole. So this is Abilify. And this one's a little bit different from our other atypical antipsychotics. It has some of the same indications as we mentioned before: schizophrenia, bipolar, mania, agitation. But it's also used, again, for an add-on therapy for refractory depression, like we talk about with our Seroquel or olanzapine. It's unique because it's also a partial dopamine agonist. So we've been talking about dopamine blockade this whole time. Well, this one has a very mild partial dopamine agonist. So you'll ask me, well, why is this working? I mean, if it's stimulating dopamine, why shouldn't it just do the opposite? Well, it activates dopamine receptors, but it's a much lower level than the natural neurotransmitter. So in effect, it's still blocking, but it's just activating it just a little bit. So this activity is thought to reverse some of the hyperprolactinemia that's seen with the typical antipsychotics like haloperidol. So letting out just a little bit of dopamine tends to help suppress that prolactin a little bit. Now, there does seem to be some sort of variable binding to other receptors as well. And because of this agonist activity, we tend not to use this medication with other antipsychotics. You can't really predict kind of what's going to happen when you combine these, so we generally leave that medicine to be used as a solo med. It also has a longer half-life than some of the other antipsychotics, so occasional missed doses, which tends to happen with patients who have schizophrenia, is not that big of a deal. So you get more steady serum levels with the Abilify or the aripiprazole. There's also lower risk of weight gain and lower risk of lipid elevation. It has a little bit less sedation and there's no major cardiac effects. So aripiprazole is a pretty good medication. It's getting more and more popular. Next, we're going to talk about paliperidone. This is also known as Invega, which is a great name. Some of these names are terrible, but that's a good one. I'd take some Invega. It's a primary active metabolite risperidone, so it's going to have a very, very similar effect as risperidone, and it's indicated just now for schizophrenia. So why are we talking about this one? Well, this one can be given intramuscularly every month. So just a once-a-month injection can give you satisfactory effect. It's still a pretty new medication, maybe not used as often as a lot of the other ones, but because it has such a long action, we tend to like using that, especially with our patients who are real resistant to wanting to take medication regularly. Acinapine. This one is also a very new medication. The only reason why I put it in here is because I thought it was kind of funny, because it has a sublingual form, and that's what makes it different. But it has a really, really bad taste. And also, on top of that, is you can't eat or drink for about 10 minutes. So you kind of wonder who's making these in the labs. Like, here's something that's going to taste awful, and can't drink anything. So I don't know if that was just a joke or what, but I think they are coming up with better tasting stuff, which will make it worthwhile. But I thought that was kind of funny. So we're going to finish with clozapine, and this is an interesting antipsychotic. It was the first atypical antipsychotic medication that was produced. Now, it has greater efficacy than any of the other antipsychotics. So for even refractory symptoms of schizophrenia, clozapine tends to do a lot better than some of the other ones. So why don't we use it? Well, because it's really hard to take and it can kill you. I mean, it really doesn't do it that often, but still, it's a pretty serious medication. Now, what's great is that it has almost no extrapyramidal side effects. And the reason is probably due to its very serious anticholinergic effects. And the side effects that you'll get, what we've just described so far throughout this lecture, orthostatic hypotension, sedation, severe constipation to the point of fecal impaction and major problems. You can also get major weight gain. Now, one thing that's different than some of the other medications is that instead of getting dry mouth, you start drooling, so you'll get increased saliva. And then you can get even severe things like myocarditis, and you can get seizures. Now, the most important side effect that you need to remember, and this will be on test, is agranulocytosis. So this occurs in 1 to 2% of patients in the first 6 months of taking the medication. It does become less frequent afterwards, but it is a very, very big deal because it can lead to death. So you have to check white blood cell counts weekly for the first 6 months of taking this medication. You can increase that to biweekly for the next 6 months, and then monthly after that. So you have to do a lot of blood draws, and so you're going to put on clozapine. Now, we still use clozapine. It does sound like a horrible medication, but for patients who fail on other atypical antipsychotics, if they're failing on typical antipsychotics and they're not doing well, we tend to still use clozapine for those patients. Also, in patients who have had problems with extrapyramidal side effects with some of the antipsychotics, we'll go for clozapine because of the relative absence of EPS symptoms in them. Now, one brief note about maintenance therapy. Now, patients who have had 2 or more psychotic episodes secondary to schizophrenia should really be on maintenance therapy for at least 5 years. And I would say probably the majority of psychiatrists I've come into contact with would say, if you've had 2 major breaks and you have schizophrenia, you really need to be on medication probably forever because the likelihood of it happening again is really, really high. So that's going to conclude our lecture today. I hope you found it enjoyable talking about the neuroleptics today. I hope that you never have to use any of them. And if you ever get a chance to get cool glasses like these, I would recommend getting some.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Well, Doc, I think I might be going crazy.
What do you mean?
Well, I have this constant feeling as though someone is watching me, following me wherever I go, and even controlling my words and actions. Sounds paranoid, huh?
Actually, I would say it sounds perfectly normal.
Normal? There is nothing normal about that. I am going nuts. You've got to help me.
Yes, it's normal. I myself even feel that way from time to time.
Of course you do, Doctor. You're a puppet.
Excuse me? What?
You're kidding me, right? You've never noticed the guy down there?
What guy? You just may be delusional after all.
Wow. Really? That guy down there? The one with his hand up your butt? Ring any bells?
I don't know what you're talking about. You say you can see this person? Right now?
Come on, Doc. He's moving your mouth and talking for you.
Uh-huh. Visual and auditory hallucinations, persecutory delusions of mysterious beings that control the people around her. It's going to be okay, Joan. I'm going to start you on olanzapine, an atypical antipsychotic. It has a lower risk of extrapyramidal side effects compared to the older neuroleptics. It can be associated with increased risk of metabolic syndrome and diabetes, so we'll need to monitor your blood sugar occasionally. And you let me know if you have increased urination.
Well, thanks, Doc, I guess.
Hand up my butt. That's a new one.
Okay, let's look at quick review number 2 in your study guide. The first question, are patients more likely to get galactorrhea with a typical or atypical antipsychotic? Well, galactorrhea is more common with typical antipsychotics. They have relatively more action on the dopamine receptors. And remember, we said that when you block the dopamine receptors, you're going to get increased prolactin, and the atypicals are typically going to block the serotonin receptors. So the typical antipsychotics block dopamine, increase prolactin, and are more likely to cause galactorrhea. Next question, place the following typical antipsychotics in the appropriate category. And you see the list of drugs there. So the high-potency neuroleptics, the high-potency typical antipsychotics are haloperidol and fluphenazine, and the older, lower-potency antipsychotics are thioridazine and chlorpromazine. Next question, which atypical antipsychotic has the highest incidence of extrapyramidal symptoms? Well, this is risperidone. Remember, risperidone has almost no anticholinergic effects, and it's the anticholinergic effects that reduces the incidence of the extrapyramidal symptoms. The incidence of extrapyramidal symptoms with risperidone is still much lower than you get with typical neuroleptics, like haloperidol, but it's much higher than you get with other atypicals. Next question, what would be a good antipsychotic medication to use in a patient who has had extrapyramidal symptoms in the past? Well, one option for this would be quetiapine. Even at high doses, there's a very low incidence of extrapyramidal symptoms because quetiapine has a very strong anticholinergic effect. Another drug you could use would be clozapine, but that's really, again, only used as a last resort because of all the dangerous side effects associated with clozapine. Next question, which antipsychotic would be a good choice in a patient who has had hyperprolactinemia in the past? Well, this would be a good opportunity to use aripiprazole. Remember, what causes hyperprolactinemia? Blockade of dopamine receptors. So aripiprazole is a partial dopamine agonist, so you're going to avoid some of that hyperprolactinemia. Next question, which antipsychotics would be a good choice for an obese diabetic patient? Well, remember that lots of antipsychotics, lots of these atypicals cause weight gain, but ziprasidone has a low risk of weight gain and a low risk of diabetes, and also aripiprazole has a relatively low risk of weight gain. Next question, agranulocytosis is a side effect of which antipsychotic? Well, this is really important to know. The only one that causes this is clozapine. About 1 to 2% of patients on clozapine will get agranulocytosis in the first 6 months of treatment. That leads us to the next question. How often should you check a white blood cell count in a patient who has just started on clozapine? Well, you want to check the CBC, or the complete blood count, so you're looking at your white blood cell count, once a week for the first 6 months. So every week while they're on this drug, for the first 6 months, they've got to come in and get a CBC drawn. And then for the next 6 months, you're going to check it biweekly or every 2 weeks. And after that, you'll check it monthly or about every 4 weeks. Next question, in what scenarios would you want to use clozapine? Well, when a patient has had treatment failures with other antipsychotics, remember, clozapine is really the most effective antipsychotic we have, so if they failed other drugs, clozapine might be something you have to reach for. The other option is when a patient has had extrapyramidal symptoms on other antipsychotics. So clozapine doesn't really cause extrapyramidal symptoms because of its strong anticholinergic effects. So that's it for quick review number 2. Now pause the video and complete the end session quiz, then restart the video and we'll go through the quiz together. All right, let's go through the end of session quiz. Number 1, what are the mechanisms of action of neuroleptic agents? Well, neuroleptics block the D2 dopamine receptors and the serotonin receptors, both 5-HT2A and 5-HT1A. This leads to a decrease in both the positive and negative symptoms associated with schizophrenia. Next question, why are atypical antipsychotic medications better than typical antipsychotics at treating the negative effects of schizophrenia? Well, the atypical antipsychotics block serotonin receptors, 5-HT2A and 5-HT1A, which are better for treating the negative symptoms. The typical antipsychotics work on the dopamine receptors, which are more responsible for the positive symptoms. Next question, the typical antipsychotics are better at treating what type of symptoms? We just said it, the positive symptoms. Next question, explain briefly the proposed mechanism of action of each of these effects of neuroleptics. So what is the proposed mechanism of action for the extrapyramidal effects? Increased cholinergic activity due to a lack of dopamine inhibition. This is why, as we've said, the more anticholinergic effect a drug has, the less likely it is to cause the extrapyramidal symptoms. How about galactorrhea? This is due to increased prolactin due to lack of inhibition by dopamine. If you block dopamine, you're going to increase prolactin, and that will lead to galactorrhea. And then finally, sedation. This is blockade at the H1 histamine receptors. Just like the sedating antihistamines, such as diphenhydramine, they block histamine receptors, they block the H1 receptors, they're going to make you sedated. So these neuroleptics that block histamine receptors can also sedate patients. Next question, match the drug to the unique characteristics. So the first one is chlorpromazine. Chlorpromazine can be used to treat hiccups. It's the only drug that the FDA has approved for the treatment of hiccups. And here's a tiny little pearl of wisdom for you. You'll probably never use this, but the medical term for hiccups is Singultus. Next one, aripiprazole. This is the partial dopamine agonist. Risperidone is most likely to increase prolactin. And clozapine causes a potentially fatal agranulocytosis in 1 to 2% of patients. Next question. Match the following clinical descriptions with the most appropriate therapeutic agent. So a 34-year-old obese bipolar man, of this list, ziprasidone would be the best choice because it has a low risk of weight gain. The next one, a 57-year-old schizophrenic homeless man who has trouble remembering to take his medicine. You can give paliperidone because it's a once-a-month injection, an IM injection. If you can get this patient who's homeless, who's schizophrenic, who doesn't remember to take his medication, it's probably going to be there's going to be an issue with compliance or adherence. This patient's not going to take his drugs every day. But if you can get him to come in once a month and you give him his shot, he'll be good. You don't have to worry about whether or not he's remembering to take his pills. The next one, a 24-year-old woman with bipolar disorder who has trouble swallowing pills. Well, the drug olanzapine is available in an oral disintegrating tablet formulation. So they don't have to swallow, they just dissolve it in their mouth and then they can swallow that very easily. Then the next one, a 42-year-old woman with schizophrenia and a history of extrapyramidal symptoms who has trouble sleeping. Well, quetiapine would be a good choice. This one does not cause any extrapyramidal symptoms. It's sometimes used off-label for insomnia because, again, those anticholinergic effects can cause some sedation. Next question. Which atypical antipsychotic other than clozapine has a very low incidence of extrapyramidal side effects even at high doses? Well, this is quetiapine. We just mentioned that. Next one. Explain the principles of maintenance treatment for schizophrenia. Patients who have had 2 or more psychotic episodes due to schizophrenia should be on maintenance therapy for at least 5 years, and most psychiatrists would say they need to be on meds for life. So if they've had 2 psychotic episodes from schizophrenia, 5 years may be long enough, but more likely they're going to be on medication forever. Next question, what medications can be used to counteract extrapyramidal side effects? Well, one medication is benztropine. This is an anticholinergic, and as we've said before, the anticholinergic will block some of those extrapyramidal effects. And then also diphenhydramine. Diphenhydramine, as I mentioned earlier, is an antihistamine, but it also has strong anticholinergic effects, and it causes a lot of anticholinergic side effects, but that can be used beneficially in a patient with extrapyramidal effects. And the last question, a schizophrenic patient presents with muscle rigidity, altered mental status, and fever. What should you do? Well, I guess the first question is, what is this? Well, this is a description of neuroleptic malignant syndrome. And as we mentioned, this is potentially life-threatening. So again, you need to know how to treat this. First of all, you're going to stop the antipsychotic. You're going to institute supportive care. As we mentioned, IV fluids, cooling blankets, mechanical ventilation, monitor for arrhythmias and hypertension. You can give bromocriptine to restore dopamine activity, and you can use dantrolene or benzodiazepine as muscle relaxants to decrease the muscle rigidity. So that's the end of session quiz, and that's the end of this session on neuroleptics.